Good morning, everyone. Um, Welcome to the 19th Shaukat Khanum Cancer Symposium that is being held virtually this year. This is our first pediatric oncology session today. And we're very excited with that because it is being held virtually. We have representation from all over the world in this session, and we'll have speakers from different countries that will be sharing their ideas. I would like to introduce our first speaker. This is Dr. Asia Golnick, who will be joining us from St. Jude's Hospital in the United States, and she'll be talking to us about critical care in pediatric oncology patients. Dr. Asia, please go ahead and unmute your mic and share your presentation with us.
Thank you so much, and good morning. And let me just share my slides. Give me a minute. I really appreciate the invitation to speak with you all. And I'm glad, as you said, that one of the few benefits of the pandemic is that we're able to do this and come together in a way that wasn't possible before. Just want to make sure that you're seeing my slides in the correct view in presenter mode. So as you just heard, my name is Asia Golnick. I'm a pediatric intensivist at St. Jude Children's Research Hospital, and I am the director of our Global Critical Care and Eurasian Regional Program. And I was asked to speak about critical care in pediatric patients with and without cancer during the COVID pandemic. I don't have any disclosures. So the overview of what I wanted to talk about on this topic is really thinking about critical COVID in children, and that is acute COVID, and then also MISC or multisystem inflammatory syndrome in children, and then other considerations for pediatric critical care in the midst of the pandemic. And then I'll talk specifically about what we know about COVID in children with cancer, and then share some informational resources that I think will be helpful for you if this is a topic of interest. So of course, I'm talking about this because the COVID pandemic has made a huge impact all over the world since December of last year. And now this is just from earlier this week, the Johns Hopkins dashboard reporting over 46 million global cases and over 1.2 million global deaths. And while adults are obviously quite affected by this virus, we know that older age is related to mortality. It was not immediately clear how children would be affected, but as we learn more, we saw that really children are not primarily affected by acute COVID. They represent about 1 to 2 of diagnosed cases worldwide, and this is increasing as schools have reopened, but it's still a really small proportion of all diagnosed cases. And if they do develop symptoms, they're typically mild. So the symptoms are similar to adults with acute COVID, with fever, dry cough, upper respiratory symptoms, and fatigue. Children more than adults typically have GI symptoms, and many, a quarter or even more, are asymptomatic.
See, there's a strange thing. It's cutting off the left and right of the screen, so it may be better to actually come out of presenter mode. It's a really strange.
Interesting.
Yeah, I'd never seen this before, but it's chopping up. There, perfect.
Did it get fixed?
That's great. Yes.
Okay, I'm sorry. Thank you for telling me. If something else weird happens, please tell me. I'd rather be interrupted. Severe cases of acute COVID in children are quite rare. Studies vary depending on the population they look at, but no more than 10% require ICU admission, typically much fewer. And about 2 to 4% of them patients require mechanical ventilation, much smaller than in adults. Radiologic findings are typical as in adults with bronchial thickening and ground glass opacities. And this is actually also present in asymptomatic patients. And mortality is quite low, often very low, less than 1%. And risk factors for increased mortality in children, unlike in adults, is actually younger age, particularly neonates are more at risk. Children with pre-existing conditions, male sex, that's similar to adults, and any patient who develops lower respiratory tract disease. So because you are not in the United States, you may not be familiar with this resource that I wanted to share, which is a COVID registry. This is sponsored by the Virtual Pediatric Systems, VPS, which is a quality improvement collaborative of pediatric ICUs in the United States and Canada. And originally this is used as a quality improvement tool to help ICUs benchmark their performance, comparing what their expected mortality is based on the severity of illness of children who are admitted and what their observed mortality is. So to see how they compare to what's expected. And at the start of the pandemic in March, they formed a COVID registry for critically ill patients admitted to pediatric ICUs in their network. And since that time, this is an open resource available to anybody. Since that time, they've documented over 1,800 cases of critically ill patients with COVID admitted to pediatric ICUs, with 59 deaths among over 26,000 patients tested in ICUs. There are a significant number of MISC diagnoses, which we'll talk about in a little bit. Jointly, these patients represent 11,000 ICU days, with 185 individual ICUs in North America submitting data to this registry. So it's obviously a huge resource. And the nice thing is that they have interactive dashboards. So I'm showing you screenshots of the registry, but if you go to this website, you can actually play around with these dashboards and focus on patient populations that interest you. So this map just shows the sites reporting to the registry, and the circles represent the number of patients from each site. So that kind of gives you a sense of at least the pandemic in children in the United States. And the graphs here that I chose just to illustrate some common things. So first, in terms of therapies that are used and the number of ICU days represented by them. So you could see, of course, conventional mechanical ventilation taking up the majority of that. And comorbidities. So even though these are pediatric patients, only about 40% of them are previously healthy. The remainder have either mild, moderate, or severe comorbidities. And I think one of the interesting things is I said specifically that these are patients admitted to pediatric ICUs. They're not all pediatric patients. So what you can see here is that the colors show the ages, and about 10% of patients are between 18 and 30, and something like 2% are over 30. And you can see how the number of those patients have increased through the course of the pandemic. And so that's clearly one of the impacts of this pandemic, is that adult patients are being admitted to pediatric critical care, and we'll talk about that later. So the other thing that this registry allows us to do is to look at outcomes. You can't look at outcomes on admission. You have to only look among discharges, because of course patients who are still admitted may still pass away from the infection. And so they have data on over 1,000 discharges of patients who have diagnosed with acute COVID. And of those, only 41 confirmed deaths. That represents a mortality of about 3.7%. Again, these are ICU patients with COVID. So this is a quite low mortality for ICU patients. And actually almost half of those deaths are not in pediatric patients. They're in patients who are over the age of 18. And even among those, it's not always clear that the patient actually died from COVID. You could see that maybe 2/3 of patients were clearly passed from COVID. Others may have died from other complications. In terms of what support and resources these patients use, they do use a lot of ICU resources, but actually almost half are on regular room air or low flow nasal cannula. Of course, others require high flow nasal cannula, non-invasive mechanical ventilation, conventional mechanical ventilation, and a subset requiring ECMO. And if you look at how long they stay in the ICU, the children actually have fairly short ICU stays, 5 to 6 days. And it's really the adult patients in the pediatric ICUs that are more severely ill and have longer lengths of stay. So that's the effect of acute COVID on children. And I want to spend a little bit of time talking about treatment. So if we think of the disease continuum for any patient who develops COVID infection, they would be exposed, they develop the infection, they may present to outpatient care, require hospitalization, they develop an oxygen requirement, they worsen, they require mechanical ventilation or ECMO ICU treatment, and then potentially develop death. And of course, the goal would be that you can lead to recovery at any stage of that process. And so a number of therapies have really been evaluated in this continuum, from a patient who is ill enough to require hospitalization up until the ICU. And so the first trial, and many of you know this, but just to review the most recent literature, The first trial, successful trial of an agent to treat acute COVID in adults was remdesivir, which is an antiviral. This was a randomized trial of hospitalized adults who were PCR positive for COVID, using as a primary outcome their overall clinical well-being, the 8-point clinical scale of how they're doing from death to home. And as you know, this was the first trial that really showed an improvement with a therapy, with the remdesivir group having a shorter time to recovery than the placebo group. And the important thing here is that the benefits were most apparent in patients who were on supplemental oxygen when they were randomized, when they started therapy. And patients who were already more severe, were on mechanical ventilation or ECMO, did not see this benefit. So this is a therapy that's really effective early in the course of the disease. The next therapy that has been shown to be effective, as you know, is dexamethasone. So this is the recovery trial from the UK, which actually tested a number of potential therapies for COVID. And again, these are hospitalized adult patients who are PCR positive for COVID. And their primary outcome was all-cause mortality. And what this study was able to show was that patients who were randomized to the dexamethasone arm compared to standard of care had a significantly lower 28-day all-cause mortality. And this was actually particularly seen in patients who were either on oxygen or required advanced support, mechanical ventilation or ECMO. And this benefit was not seen in patients who were not on oxygen. In fact, those patients performed worse. And so finally, just because this treatment got a lot of attention early in the pandemic, hydroxychloroquine. So there's a theoretical reason why hydroxychloroquine may be effective in COVID, but a number of randomized trials comparing this therapy at various parts of the treatment cycle. So hydroxychloroquine as post-exposure prophylaxis, at early treatment within non-hospitalized but exposed but ill patients, and hospitalized patients with mild or moderate symptoms. All three of those studies did not show improvement in patients randomized to the hydroxychloroquine arm compared to placebo. So we don't believe that this medicine has a role in acute COVID treatment. So thinking back to our continuum of the development of illness in patients with COVID, we know that remdesivir is effective if patients requiring oxygen. Dexamethasone is effective for patients who are requiring oxygen or mechanical ventilation or advanced support. And hydroxychloroquine really doesn't have a role. Of course, this is with the caveat that all of this is adult data. We don't know exactly how this would work in children. And certainly we don't know how this would work with children with cancer, but we've all extrapolated from this evidence to guide our treatment in those patients, because that's the best evidence that we have. So then, just as pediatric intensivists were celebrating that this pandemic was not affecting them as much as it was our adult colleagues, of course, you know that the situation turned somewhat. And in New York and in the United States, about 4 weeks after the real peak of the epidemic, we started to see these cases of children developing multisystem organ failure with hyperinflammation, who were either exposed or had antibody evidence of having had a COVID infection in the last few weeks. And so this is what was called now multisystem inflammatory syndrome in children, or MISC. And this is the current case definition. So it's any pediatric patient, defined as somebody who's less than 21 years old, who develops fever, laboratory evidence of inflammation, and you can see the specific definition here, and evidence of a severe illness that requires hospitalization, which involves multiple organ systems, including at least two of the following: cardiac, renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurologic. And you must not have an alternate plausible diagnosis for this syndrome, for what's going on with the patient. And the patient should either have a history of being PCR positive or having serology positive, or a good story for a COVID exposure within the 4 weeks prior to their symptom onset. And so this is the disease that presents somewhat like Kawasaki disease or toxic shock syndrome in children, although the patient population that develops this syndrome is older and much more critically ill. And as I alluded to, this was really starting to be observed about 2 to 4 weeks after the peak of incidence in a location. So this is showing the temporal relationship with the yellow curve showing the percent testing positive. This is data from the United States. And the red line showing the number of cases of MISC documented. You could see that temporal delay. So we really think this is a post-infectious complication. So we are not sure what the pathophysiology is, but we think it is a combination of autoreactivity, autoantibodies, and a dysregulated inflammatory response. What's characteristic about these patients is that they almost always require critical care. And what they require is a combination of positive pressure mechanical ventilation support, vasopressor support, and a good percentage requiring extracorporeal support, ECMO. But despite the fact that these patients have really quite severe critical illness, they have a very low mortality, only 2 to 4% reported in more recent studies. They also have some very unique complications, particularly cardiac complications. So like Kawasaki's disease, many patients develop coronary aneurysms, and a significant number of patients develop acute heart failure, myocarditis, which typically resolves as the disease improves. And there is a question of whether these patients are more prone to clotting. Clotting is a clear problem that happens in adults with acute COVID. Children with acute COVID don't seem to have the same pathophysiology, but older patients, older pediatric patients with MISC do have a higher rate of clots than typically critically ill patients. And so really this, we think of this as a spectrum of inflammation that can begin with fever and increased inflammatory markers. More severe patients have features of Kawasaki's disease with inflammation and rash and other findings. And then with the most severe patients developing shock, myocarditis, and potentially coronary. And so what do we know about treatment? There are no randomized studies, but this is the best recommendations for treatment based on our long-term experience with Kawasaki's disease, thinking that the pathophysiology is similar. And so these agents are targeting the autoantibodies and immune complexes that we think is responsible for the organ failure, trying to reduce that autoinflammation. And so just like in Kawasaki's, the first tier of treatment is IVIG. And that is really the only therapy in Kawasaki's that's been shown to reduce the incidence of coronary aneurysms. The second tier therapy, if that doesn't work, is steroids. And then finally, there's, we've used biologic agents, immunomodulators, particularly anakinra, and in some cases, tocilizumab. And I'll talk about these in detail in a second. Because there is a potential for clotting and coronary aneurysms, aspirin is recommended in certain patients, and enoxaparin, Lovenox treatment dose or prophylaxis in particular patient populations, and I'll talk about that. Antibiotics, however, are only indicated if there is clear evidence of a secondary bacterial infection, which is not common. And antivirals are not recommended in this setting because we think this is really a post-infectious complication, not a manifestation of acute COVID, although telling the difference between the two is often hard in practice. So just going through a little bit about the therapeutic recommendations. So this is the American College of Rheumatology guidelines, which are the ones that are followed by most centers in the United States. So again, they recommend a stepwise approach of immunomodulation to a patient who has suspected MISC. So the first treatment is high dose IVIG, which is typically 1 to 2 grams per kilo. Now that's important that may be a lot of volume for a patient if they have heart failure. And so sometimes that dose needs to be divided into multiple doses to prevent overfluid loading somebody who's in acute heart failure. If that is not effective, the next option would be low or moderate dose glucocorticoids. And that is either intermittent dosing or a high pulse dose can be recommended, especially in patients who are in shock or on multiple inotropes. And then if that's not effective, the next choice would be anakinra, which is an anti-IL-1. And that would be for MISC that's refractory to the first 2 treatments. And then in terms of anticoagulation, which is what is a little more controversial, I think aspirin is well used in Kawasaki's disease, and so that is a less controversial therapy, particularly in patients who have more Kawasaki-like features. The recommendations, if you don't have coronary aneurysms, that you should avoid this treatment if you're severely thrombocytopenic. However, if you do have coronary aneurysms, that's point number 2, we do want to start low-dose aspirin and therapeutic anticoagulation if they have particularly large aneurysms. That's because the risk of clotting those patients is quite high. And finally, if patients who have a very severe heart failure, so an ejection fraction of less than 35%, those are patients who definitely need to be on therapeutic anticoagulation for at least 2 weeks after discharge from the hospital. So I would say that most hospitals in the United States follow some version of these guidelines, certainly with that tiered approach to immunomodulation and some form of anticoagulation depending on their patients. But this is all, it's not based on, randomized trials. There's no evidence. This is all consensus agreement. So now I want to move on to thinking, I talked about the 2 medical impacts on pediatric critical care from this pandemic, but there's actually a lot of other impacts. And this is, I'm sure, things that you've experienced in your own setting. So obviously there are a number of staff shortages. This is a disease that affects adults, and adults work in our ICUs. And so staff are infected, they may be quarantined. And unfortunately, there's been a number of nurses and physicians who have died from this infection. Also, PPE shortages are universal these days, and they particularly affect the ICU because it's there that you're often taking care of patients who either have confirmed or suspected COVID, and you have higher needs for PPE, for protective equipment that may be not available. As hospitals have shut down and tried to decrease the number of people coming to the hospitals, actually a number of subspecialties have also become less available. And, us in critical care, we're so dependent on the multidisciplinary team, and not having access to subspecialty consultation is a real problem for our patients, even the ones that don't have COVID. That has been a real challenge, and equally a challenge has been access to surgical services. So again, in the height of the pandemic, as hospitals have shut down, surgeries were canceled, and what is considered an elective surgery is really variable depending on the setting. And often surgeries that were necessary but not emergent were canceled, and that affects our patients as well. And then finally, there's this, as was well demonstrated by that VPS data set, this new patient population in the pediatric ICU of adult patients. And I think similar to your training, us as pediatric intensivists, we are trained as pediatricians. We do not take care of adult patients. And so this is really a challenge for us to make sure we're giving high quality care to these patients. And so to address this is a very nice article that was published by one of my colleagues, Dr. Remy, who is trained in both medicine and pediatrics as an intensivist, and a team of similarly dual trained pediatric intensivists wrote this nice these recommendations for pediatric intensivists treating adults in their ICUs during the pandemic. And this was published in Pediatric Critical Care. And I really recommend this article if this is a patient population that you are taking care of. And so some of the issues they raise that I think are really interesting, just consider, are the differences between adults and children. So differences in equipment size, medication doses, and even simply just resuscitation guidelines between these patient populations. Also, adults develop a different subset of complications when they are critically ill and require a different group of consultant services in their care. Procedures are different in adults than in children. For example, you don't necessarily need to sedate an adult for a lumbar puncture or other small procedures. And another example would be that we don't typically use femoral catheters in adults, although we do in children quite often. Adults also have a whole different host of chronic conditions and home medications that we don't necessarily use in pediatrics. And we have to decide whether those medications should be continued or discontinued in critical illness. And then finally, the general strategies of how to manage an adult with critical illness is different than how we manage children. An example of that is prone positioning. There's much more evidence for prone positioning in adults with ARDS, and particularly for adults with COVID. And that is used, but not as commonly in children. And certainly a pediatric ICU, which is maybe not as used to proning patients, having to prone adult patients, that's complicated and potentially dangerous. And so I think this is a nice thing to consider if you're in this situation where you're taking care of a patient population with whom you're not familiar with. This is a nice reference discussing those challenges. So then I want to move from kind of the general pediatric ICU perspective on COVID specifically to pediatric oncology patients. And that's, of course, our focus at St. Jude. When the pandemic hit and we had adult data, there was really a concern that these patients, pediatric oncology patients, would be at risk of severe disease because there was adult evidence that adults with comorbidities, particularly with immunosuppression, had much worse outcomes. Luckily, as smaller studies that have been published have really suggested that children with cancer overall do well, even if they develop acute COVID. Just like other pediatric patients, there's a small subset that develops severe illness, and only a few develop mortality. However, those are impacts directly from the infection. There are actually much greater other impacts of the COVID pandemic on pediatric oncology patients. Patients who are diagnosed with COVID, even if they're not necessarily ill, often will have treatment modifications, and that can affect their long-term prognosis from their primary disease. Also, in the shutdown of hospitals and the impact on health systems, there's been a huge, well-documented effect on the ability of hospitals to deliver childhood cancer treatment to patients in general during the pandemic. And this is seen by many hospitals, including in the United States, reporting decrease in the number of new diagnoses of childhood cancer that they see, not because children are suddenly not developing cancer, but because children are not making it to the hospital on time. And so there's been later presentations than are typically seen in those settings. And because families are maybe not able to make it to the hospital because of shutdowns or financial constraints, many centers have documented an increase in abandonment. So the effect of the pandemic on pediatric oncology patients has actually been more of these secondary effects than the primary impact of COVID. And so when thinking about resources to understand the effect of COVID on children or children with cancer, St. Jude Global partnered with PSYOP to create this global observatory, the COVID Observatory, which is the website's there, and it's intended as a global resource for providers who take care of children with cancer that provides three things. The first is a library, and I'll go through these in detail, but a library that has curated documents and resources, an interactive collaborative space, and a registry. And so I'm going to talk through those pieces right now. The library is curated references, articles about a number of topics, including these things: COVID and pediatric oncology, general information about COVID, treatment and disease, information about prevention, and then great references for healthcare providers and also patients and families. So I recommend you check that out. The second piece is a collaborative space. So that does require a login, but that's free and anybody can get one. And the idea is that everyone who treats children with cancer has been affected by this pandemic worldwide. And often there are really good solutions to some of the challenges that people face across different institutions. So this isn't a way to bring people together to collaborate and share their experience. So it's a way to pose questions, to get answers, to maybe answer somebody else's question. And this links collaborators all over the world. And finally, there's the registry, which is a registry of children with cancer who develop COVID. And the link to the registry is there. You're, of course, invited to enter your own cases. But this is intended not only as a research tool, this is intended as a resource for all of you. And so if you go to this website and you go to the registry site, you'll see that light blue square, which says visualize the data. And that is actually a up-to-date visualization of the active registry data. And so this is from 2 days ago. At that point, there were 986 cases of children with COVID recorded worldwide. You can see on the map where they're from. They're from 42 countries. And the nice thing here is that all of this is interactive. So if you want to know about just the leukemia patients, you can click on that part of the dashboard and it will adjust all of those dashboards for those patients' population. So it's meant to be a resource for people to explore and to really learn about what's in the data. And so I encourage you to go to that website and check it out. But I'll show you a little bit from what's there right now. So among that almost 1,000 cases, you can see that the distribution by age. Typically the children affected are the common children who have cancer, that middle age group. Most patients have leukemias, but of course there's a number of other diseases represented. And then in terms of organ involvement, most patients have mild disease, so constitutional symptoms or no symptoms at all. And then of course some organ involvement. And just as I mentioned, really critical illness is not that common in these patients, so less than 10%, and over a third being asymptomatic. In terms of what care they require, 83% require no higher level of care, but then of course a subset do require some form of intensive care. And then in terms of what type of respiratory support they require, most only require room air, but of course there's a subset that require advanced mechanical support. The registry also looks at 30 and 90-day follow-up. So this is the 30-day follow-up of patients. And what you can see is that most recover from their infection and only a small subset, about 5%, die from COVID. Of course, there's another small subset that passed from their underlying disease or some other complication during that time. But as I mentioned, while the impact on the patients is not necessarily directly mortality, there is a number of impacts on their cancer-directed therapy. And so you can see that over a third have had chemotherapy withheld or reduced, and delays in either their radiation or their surgery as well. And so that may affect their long-term prognosis from their oncologic disease. And finally, I want to just share a few other resources with you that may be helpful. So that dashboard that I showed you in the beginning comes from Johns Hopkins, and that's available for anybody to explore. You can look at your country, you can look by dates. It has a lot of cool information. This is the link to that VPS dashboard that I mentioned that again is interactive and can be accessed by anyone. And finally, MGH, which is a hospital in Boston, has this resource called FLAIR, which is a fast literature assessment and review. And they provide kind of up-to-date assessments and interpretation of literature that comes out around COVID. I think one of the challenges has been that so much has been coming out of various quality, it's hard to really keep current. So this is a good resource because these are experts who have gone through the literature and kind of synthesized it for you. And they also have a number of guidelines and other references that are in many languages that are, it's a nice composite of all of the information that exists around the world. And so I just want to end by saying that I'm speaking to you on behalf of our program, which is the Global Critical Care Program at St. Jude Global, which aims to improve the management of children with cancer who develop critical illness all over the world. And we currently have over 650 collaborators from over 53 countries working with us. And so our program works in these kind of 4 areas. We do a lot of quality improvement, implementing evidence-based interventions, with the biggest project that we have is a multi-center pediatric early warning system quality improvement collaborative in Latin America, but then a number of other quality improvement work. We do a lot of research in this field on quality and communication and implementation science. And we also do a lot of education. So we have an annual conference, we have a global academy in pediatric oncocritical care, which is I think how you learned about me in the beginning. And all of this is to aim to form a horizontal collaborative network, a collaboration of providers who are interested in this patient population and want to improve their care. And so I invite you, if this interests you, to join us, send us an email and join our listserv, or invite one of your colleagues. And if the topic, pediatric oncocritical care, is interesting to you, St. Jude has an annual conference in April. This year, thanks to the pandemic, it is virtual. The dates are there. Registration will open soon. So if you're interested about that, email us and we'll make sure we pass on that information to you when it's available. So with that, I thank you again for the invitation, and I'm happy to take questions.
Thank you so much, Dr. Agulnik, for that excellent presentation. I think there are questions, but we actually have to move on to our next talk. So what we might do is maybe email the questions to you and then post the answers, or find a way of getting back to the people who asked the questions. And thank you so much. That was really excellent.
Yes.
Our next speaker is also from the United States and same city. So also from, I would like to invite Professor Scott Howard. He's a professor at University of Tennessee, College of Health Sciences, Memphis. And he is going to talk to us about the importance of molecular biology and cytogenetics in pediatric acute lymphoblastic leukemia. So Dr. Howard, if you can please unmute your mic and share your screen. And please turn on your video as well.
Well, it is such a pleasure to be with you. Can you see the entire screen or only part of it?
We can see the entire screen.
Great. So I am really happy to be following on Asya because I think to cure a patient with cancer, we need multiple components. And the supportive care is one of the most critical. And now I'm going to go back and talk a little bit about the diagnosis and risk stratification, molecular biology, and cytogenetics. So here are my 3 points, but there's really only one message, which is focusing on the most important prognostic factor for patients with ALL. So nowadays, treatment based on molecular biology is the standard for ALL, AML, myelodysplastic syndrome, CML, myeloma, anything you want to think about. Many cancers have molecular biology as the standard for both diagnosis and treatment. But the molecular-based therapies actually require an individualized approach. And I'm going to show you one example of a technology system that basically helps you make sense of patients who have multiple mutations, upregulated genes, downregulated genes, deactivated genes, and so on. And then the third component is that targeted therapies are less important than effective therapies. And I'll show you what I mean by that. So point number 1, treatment based on molecular biology is now the standard in many cancers. And here we have children on the left, adults on the right. And so notice here, for example, Philadelphia positive ALL, 1/4 of adults, 3% of children. So that's the one where we know what to do, give chemo plus Imatinib or chemo plus Dasatinib or chemo plus Nilotinib or chemo plus Ponatinib. But basically it's chemo plus some tyrosine kinase inhibitor. And then a bunch of other slices to the pie. So the dream is that one day we'll have a specific therapy for MLL rearranged patients. I'm sorry, this is in Portuguese, long story. But for MLL rearranged patients, we see that's 8% of children, 10% of adults. It turns out there's actually a medicine in phase 1 studies that is only useful for translocation 411. So it's extremely specific. It's called a menin inhibitor because translocation 411 dysregulates the menin and then leads to overexpression of the growth genes and the survival genes and then develops into ALL or sometimes AML. So what is the most important prognostic factor in ALL? I will let you meditate on this and type it in the text. Come on. Well, while you're thinking about it, I will give one idea of what it might be. Do you think it could be possibly genomics or transcriptomics or maybe the exome or which slice of this pie you find yourself in? Like all these red slices, all those are T-cell ALL. All the blue slices are B lineage ALL. Hyperdiploid, well, that's got to be good. ML rearrangement, that's got to be bad. Philadelphia chromosome, that's definitely going to be bad. Tel AML, going to be good. So I am seeing some typing here. This is fantastic. Treatment, response, and response to treatment. So this is the perfect combination of answers. So is it molecular biology? Nobody answered that that's the answer. Cytogenetics? Nope. So the title of this talk, which was assigned to me, is the molecular biology and cytogenetics of ALL. But it wasn't assigned because this is the most important prognostic factor. Because the most important prognostic factor is treatment. No doubt about it. By far and away, the most important. And how do I know? Because imagine you develop ALL and somebody says, I'm going to treat you with green tea. 0% event-free survival using green tea for ALL or AML or anything else for that matter. Why? Because it's not an effective therapy. What if I say, oh, I'm going to give you the St. Jude Total 16 therapy that's published and worked great to 88% event-free survival? Well, that's a much better treatment than green tea, for example. So we go from 0% to 88% just by the treatment. That's by far the most important. It doesn't matter if you have every good cytogenetics. If you get bad treatment, bad prognosis. And what about Imatinib and Dasatinib? That should be treating the red slices of the pie here, the Philadelphia positive patients. And I won't bore you with the details. Of course, we have the ABL gene and the BCR gene. When you have the translocation 922, BCR and ABL are put next to each other, and the growth is overdrive. The survival is in overdrive. The cells proliferate and survive and cause acute lymphoblastic leukemia. But of course, we know you can give imatinib, and here's imatinib, the orange circle here, that inhibits this fusion protein and restores the cells to normal function. So that's great, but does it actually work in real life? Because it's a targeted therapy, it's targeting something just like the menin inhibitor is targeting 411, but will it work in real life? That's the question. Well, it turns out imatinib has been carefully studied. So this study, AALL0031, is a study of the Children's Oncology Group. And you notice they were measuring MRD like crazy. And most of the time, when I ask people what is the most important prognostic factor, they say MRD at the end of induction, which is pretty close. It's actually maybe the second most important prognostic factor, but number one is treatment. So this study, I really love it. I just love it too much because it was so carefully done. Cohort 1, 2, 3, 4, 5. And what was not known at the time of this study, it was published in 2009, as you see down here by Kirk Schultz, but it was done in, earlier, much earlier than that, 10 years before that, because nobody knew if the intensification block was safe to give with imatinib, or if intensification 2 was safe to give with imatinib, or if imatinib could be given safely during maintenance. So cohort 1 was basically, hey, let's add the imatinib here, here, and here. And everybody thought it must be pretty safe during maintenance. If it's safe at all, it should be safe during maintenance. But then the next cohort, cohort 2, said, well, we won't give it with these periods of time. We'll give it with the reinductions and the consolidation, but also during the maintenance. And cohort 3, hey, let's try consolidation 1. And then cohort 4, fill in the gaps. And cohort 5 started during induction and finished at the end of chemotherapy. So really great study design. And comparing to historical controls of children with ALL, Philadelphia positive ALL treated by any means possible, usually with chemotherapy plus transplant. And they had a 5-year survival of about 30%. Meanwhile, the 4-year survival with imatinib, 80%. So here's a difference of about 45% with chemo without imatinib, chemo with imatinib. So that's a pretty big difference in prognosis. And what was the difference? It was not MRD, it was not the molecular biology, it was not the cytogenetics, it was the treatment, which is by far the most important prognostic factor. And here's just an example of a counter argument, because cohort 3 and 4 of this study, MRD negative patients had 100% event-free survival. So that's pretty good, hard to improve on that one. And the MRD positive patients, and by positive, I don't mean grossly positive, I mean just greater than 0.01%. Look at this thing, they were just dropping like flies. By 4 years, only 25% event-free survival in the cohort 3 and 4 who had a positive MRD at the end of induction. And remember, cohort 3 and 4, they got a lot of imatinib. They didn't get continuous imatinib like cohort 5, but they did get a lot, just a few little gaps in cohort 3 and 4. So when I ask you what is the most important prognostic factor, if you say MRD, I can't argue with you too much, because in cohort 3 and 4, MRD was really, really important. I mean, the difference in 100% versus 25%, that's a big difference. And yeah, of course, these are small groups and all that, but the point here is that cohort 5, equal prognosis, MRD negative or MRD positive, p-value 0.416. So you could argue, well, wait a minute, this is a big difference in prognosis. But what happens in cohort 5, their prognosis is the same because why? They got better treatment. And if they had perfect treatment, it would be 100%. All the way out here. So the day we reach 100%, there will be no other prognostic factor besides treatment. Did you get the 100% treatment or did you get anything else? And so the better the treatment, the less relevant the prognostic factors. And I don't know how you're doing in Pakistan, but in the US, in the old days, a lot of people gave boys an extra year of maintenance therapy. Why? Because they had a worse prognosis than the girls. So the thinking was just add a year of maintenance and maybe we can bring them up to be equal to the girls. So it's sort of like cohorts 3 and 4. You could say, well, if you're MRD positive, why don't we give you something extra and hope to bring you up here? It turns out in modern therapy, this is not necessary anymore. So in total 11, it was important. Total 12, total 13, total 14, 15, 16, 17, not important. COG studies also no longer treat the boys longer than the girls. So why do they not do that? Because the prognosis is so much better for everybody that you can't even see a difference in the boys and the girls. In the COG, the most recent study where they treated everybody the same, the boys actually were than the girls. So it was like 87% versus 85% event-free survival. It turns out that actually was statistically significant because they treated so many patients on the most recent batch of COG studies. But clinically significant, I would say not. And nobody ever proved that an extra would boost that 2%. But for sure, it would create toxicity and hassle factor. So what is the most prognostic factor in ALL? Well, it is not MRD, it's treatment. We had a patient at St. Jude, actually, who was 18 years old, which is the age in the US when you can make your own medical decisions. And he actually had a TEL-AML positive, but he was 18. At the end of induction, his MRD was negative. And I wasn't his primary doctor, but his doctor went there and said, hey, great news, you're MRD negative. And he said, well, that is great news because I have been praying to God to be healed of this ALL. And the fact that the MRD is negative tells me that God answered my prayer and healed me of this leukemia, and I'm going to go home because I've been healed. And of course, the doctor and the social worker and the psychiatrist and the parents and another doctor and another social worker and another psychiatrist and every relative tried to convince him, no, you've got to take the rest of your treatment. MRD negative does not mean eradication of all leukemia. In fact, you can still have 10 billion leukemia cells in your marrow and be MRD negative at the 0.01% level. So MRD negative has nothing to do with leukemia eradication. Well, it's proportional, but it is not indicative of complete eradication of leukemia. So that boy went home, he relapsed, and he died of relapsed ALL. And so that tells me he had a great prognosis, but he didn't get the right treatment. So his prognosis went down to 0 because he didn't get the right treatment. And it's even more interesting in the cohort 5 chemo plus imatinib versus chemo, imatinib, and transplant versus chemo, imatinib, and unrelated transplant. So not only is chemo plus imatinib giving greater than 80% event-free survival, it's also giving a better event-free survival, or at least equal to transplant plus chemo plus imatinib plus transplant. So not only is it a better prognosis, no need for transplant. So what is the most important prognostic factor in ALL? Well, it is not transplant, it's chemotherapy plus a tyrosine kinase inhibitor. And I know what you're thinking, well, that's nice for that one COG study with 5 cohorts, small sample size, et cetera, et cetera. So I was really glad to see this study from the SFAL group, the European group, and they had a randomization here and some poor risk patients. And the randomization, though, was all of this stuff here is the tyrosine kinase inhibitor, all the purple. So the randomization was basically get a bunch of chemo or get a bunch of chemo plus the tyrosine kinase inhibitor, in this case, imatinib. And the high-risk group, they got imatinib without randomization. So this group we're not going to talk about more. We're going to compare this group to the same group plus the imatinib. And of course, they gave it in a way that we wouldn't do anymore. It was blocks, and then nothing, and then another block, and then nothing, and then a block. So nowadays, start the imatinib during induction, continue the imatinib all the way, and the last day of treatment is the last day of imatinib. And that's pretty much the global standard now. Let's look at the bottom line here. No imatinib, yes imatinib. So this was not as dramatic as the COG study, because look, 70% with imatinib, and over here without imatinib, 58% or something like that. And only 46 patients in each study group. And the cumulative incidence of relapse was not that different in the 2 groups, but there were more deaths in the group that did not get imatinib. And that's probably because more people got transplanted. So no imatinib, yes imatinib. Again, what's the most important prognostic factor? Chemo versus chemo plus imatinib. Well, in this case, it was adding imatinib. It was the treatment. I hope you would never show a slide like this, because some people will look at this slide and they'll be looking over here on the right-hand side when you're trying to draw their attention to the left-hand side. So it's PowerPoint. Why not just show this? It's bigger and you can't get distracted, because all you see here is no Imatinib, yes Imatinib. And you also see, once again, a small sample size down here. I think you know treatment. So the next question is, if Imatinib plus chemo is good, is Dasatinib plus chemo even better? At St. Jude, as you know, or many of you know, we switched in total 15, it was chemo plus Imatinib. In total 16, it was chemo plus Dasatinib. But of course, only 3% of children have Philadelphia chromosome positive. So there were like 500 patients on total 16, which means only 15 of them had Philadelphia positive. So it's not enough to say whether Dasatinib plus chemo is any better, and it wasn't randomized, it was sequential, supportive care improves, a lot of other things improved. So this study I thought was great because it was randomized between Dasatinib 80 milligrams per meter squared. The only downside was, look at the Imatinib group, 300 milligrams per meter squared. So COG used 340 milligrams per meter squared. Other people use 400 or even 600 milligrams as a fixed dose in adults, sometimes even 800 milligrams. So the one tricky thing about this study is the Imatinib dose was a little on the low side. And you know how it's going to end. Imatinib is the loser in this study. P value 0.007, hazard ratio for relapse 2.36. And when you see 2.36, you think to yourself, well, wait a minute, does that mean Dasatinib is twice as good as Imatinib? And the answer is, depends on how you look at it, because the hazard ratio here is the hazard of relapse. And so Dasatinib, let's look at, say, 3 years. The hazard of relapse by 3 years of Dasatinib is 20%, and Imatinib is 40%, because it goes from here down to here. So if you say, well, it's 40% versus 20%, it's twice as bad. But you're curing 60% of people here and 80% of people here. So you could argue, well, it's not twice as good. If you're curing 60% here, twice as good would mean you're curing 120% to be twice as good as this group. So from a relapse point of view, the hazard of relapse is twice as high. From an event-free survival point of view, the Dasatinib group did about, I think it ended up being like 18% better than the Imatinib group. But look at the Imatinib group, they didn't really do that well compared to the COG study or the European study. So that's one thing to keep an eye on, because probably, if you had to guess why they didn't do that well, I would guess because they got a lower dose of Imatinib. And what's the most important prognostic factor? The treatment. And so if you get a lower dose of a critical agent, it probably could drop you 5%, 10%, who knows? So it may be that Imatinib 400 per meter squared, 500 per meter squared could be equal to Dasatinib. And I would say if I were alone on an island and had to treat a Philadelphia positive ALL patient, I wouldn't feel at all guilty if I needed to give them Imatinib because that's what I had in my hand, or because that's what they could afford, or because it was generic in my country and the government would cover Imatinib but not Dasatinib. I don't think we need to feel guilty at all, but we do need to use the Imatinib at the higher dose, round up on the dose of Imatinib. So we used to think, and here's a presentation that I copied from something in Brazil, which is why some slides are still in Portuguese. But this wonderful speaker talked about one gene, one cancer, one magic bullet. And this whole idea used to be the idea of personalized therapy. You find that gene in that cancer and you give that magic bullet and the patient will do well. This is great for CML, it's great for APL. APL is even better. We have 2 magic bullets, ATRA and arsenic. So if you shoot both bullets at once, the APL patients will do well. CML, it's great to have a bunch of magic bullets that all do the same exact thing. The downside, though, is that most cancers have 4 or 5 driver mutations, and it's extremely heterogeneous from patient to patient, tumor to tumor, clone to clone. So even in the same patient, within some clones may be resistant to some things, there may be 3 driver mutations in one clone and 4 different ones in another clone. Maybe 3 are in common and some are different clone to clone. So what to do about this? Well, one thing you could do is, in Philadelphia positive, you could do gene expression profile. You could find the, where's the Philadelphia-like group here? Let's find it. All right, how do you find it? You say, well, here's BCR-ABL. They have low expression here and low expression here. So which group is sort of like that? And it was this group here where they said, well, this group is not falling into any other category, but they have a lot of genes in common with the Philadelphia positive patients. So it's Philadelphia-like. What is Philadelphia like? It is very, very important, extremely important. It's not the most important because treatment is the most important. But after treatment, then this is really critical for prognosis. And the types of Philadelphia-like, here's the downside. It's not one gene, one magic bullet. It's a bunch of different genes. It's CRLF2, it's kinase fusions, various kinase fusions. In green here, that's not just one kinase fusion. It's mutations in the IL-7 receptor, FLT3, SH2B3. It's patients who have RNA-seq, no change, but have some other finding that you can only find with RNA levels, and then some others that just haven't been figured out yet. JAK2 is involved frequently. If we go up here in blue, JAK2 in young adults, JAK2 in adolescents, and JAK2 in childhood. So think of the young adult, this 25, 30-year-old, many, high percentage of JAK2. Now what's tricky here is all of these are pegged at 100%. So this is not telling you that there's, 40% JAK2 mutations in young adults. What it's telling you is of the BCR-ABL1 like ALL, Philadelphia like ALL, most of those are JAK2 mutations in young adults. In kids, it's maybe 10, 15%, still important, but it's not most of the patients. And here's ABL1, ABL2 in red. Keep that in mind. I'll show you in a sec. Okay, the second is now. So on the left here, we have the JAK pathway, and on the right, we have the ABL pathway. And I know of all the people listening right now, possibly only 10% of us care about pathophysiology and specific mutations. I might not even be in that 10%, except that here it kind of matters. And that's, look, CRLF2, IL-7 receptor, EPO receptor. Any of these surface molecules can mutate, or here's the pathway. So you stimulate this, it stimulates this, it inhibits JAK2, it does this, it goes here, it does this stuff, goes to the nucleus, and finally causes the overgrowth and the oversurvival of this cell. So the good news here is that all of this stuff, any mutation in any of these is JAK pathway. Any mutation of any of these other ones is ABL pathway. So to my mind, all we have to figure out is it a JAK problem or an ABL problem? Red or blue? And you know what? This slide was made prior to the US elections. So you may have seen many maps of the US with all the red and the blue here, but those colors were chosen randomly and do not express any political opinion. So here's these mutations respond to Dasatinib. These mutations respond to JAK2 inhibitor, Ruxolitinib. This one, JAK2. So when you think, what am I going to do about it? Philadelphia like ALL is not just academically interesting, it could use targeted therapy. And we don't have time to go into it, but the key here is not which mutation, but it's which targeted therapy, either Dasatinib or Ruxolitinib, or neither one. But never both, because if it's a Dasatinib driver by ABL2, it's never a JAK2. So it's one or the other. And you can use phosphoflow cytometry and give Dasatinib and see if it changes the phosphorylation pattern when you then do, this is like a phosphoflow over here. So here's really interesting. Philadelphia like ALL, children, adolescents, and young adults in Children's Oncology Group, COG. COG's great centers, great hospitals, great study. Here's the St. Jude experience. Philadelphia like, non-Philadelphia like in blue. Uh-oh, no difference at St. Jude, big difference in COG. What happened? Why did this mutation, family of mutations make such a big difference in COG and no difference at all at St. Jude? Well, I know by now you're going to get this answer in 0 seconds. It was the treatment. The treatment at St. Jude during this whole period was determined by the MRD. And the patients with the Philadelphia-like usually were MRD positive at the end of induction. So they got put on the high-risk arm, they got high-risk therapy, and they got cured. 80% of the time they got cured. During the same time period, late 90s in COG, nobody was using MRD to manage patients. It was considered experimental at the time in the Children's Oncology Group. So if you don't use MRD, some of these patients got low risk therapy and they relapsed, and some died after they relapsed. So again, the treatment, you don't need ruxolitinib, you don't need dasatinib, you need good chemotherapy based on MRD, and you're going to cure 82% of these patients with Philadelphia-like. So what's the most important prognostic factor in Philadelphia-like ALL? It's the treatment, and it is not targeted therapy. It's MRD guided therapy using the intensity of treatment that is corresponding to the need. So what in the world? Okay, so what treatment is going to get us to 100% event-free survival? We are not going to talk about this, because what I want to talk about is to let you know you don't have to learn everything today, because again, there are tools and networks here to help you. And here is the Genomics and Hematologic Cancer Network. I invite you to join it. You go here to resonancelehealth.org, log in and click on here, and feel free to join. And that's the place where we can discuss the cases, review what to do, and so on. So I want to show you, how do we boil it all down? Somebody hands you a Foundation 1 report or some kind of next-gen sequencing report, and it typically will show all of this stuff. This is a lung cancer one. So all of this is first line, all of this is second line, all of this is systemic therapy. How do you make sense of all this stuff? And so CellWorks is actually a company that I don't really have any relationship to them, except that I've used their report a couple of times and found it really interesting. I know there might be 10 of these type of companies, but I'm just going to show you this one as an example because I happen to have the data. So they use a modeling process that is too complicated to explain or understand, but here's the bottom line. They start with a healthy cell and recreate all the pathways of a healthy lymphoblast. So let's just say this is a normal lymphoblast. There's FLT3, there's RAS, there's KIT, there's NF-kappa beta, there's TP53, WT1, you know, a lot of these genes and pathways you recognize. I never really thought about how they're all put together, and I found this diagram very helpful. But the bottom line is all of these are inhibiting survival. All of these are promoting survival. All of these are inhibiting proliferation, and all of these are promoting proliferation. So it won't surprise you that in some cases, if all of these are upregulated and these are downregulated, there will be more proliferation, and similar and vice versa. So I'm not going to go into this in detail, but just picture a patient who has a next-gen sequence report, and it says, oh, they have a mutation in this, 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 and this. And the blue mutations are a gain of function. The red mutations are a loss of function. And remember, the average cancer has 4 to 5 driver mutations. So this patient happened to have 5. But how does it all work? You know, 1, 2, 3, 4, 5. So what if you had a KIT inhibitor? Would that actually rescue this patient? Would it destroy their cancer? No, it would just mess up this one part, but this thing would still keep going. So the question is, what treatments do I need to give this patient to cure this particular patient? And here's the consequence. When I upregulate this one, all of this green stuff is upregulated. And look at this, it ends up upregulating all of these. So it's driving proliferation and it's driving survival. And look at this, the patient downregulated the inhibitors of proliferation and downregulated the inhibitors of survival. So you end up with way more proliferation, way more survival. And of course, that's what leads to the cancer. If you give midostaurin, this is an AML patient, it turns out, then midostaurin is a FLT3 inhibitor. Remember, this patient did not have FLT3. It's a wild type FLT3, normal FLT3. This patient had mutations elsewhere. But it turns out midostaurin blocks PRKCA, PRKCB, it blocks FLT3, and it also blocks KIT. So in this particular patient, the midostaurin actually led to a remission. Why? Because it turns out midostaurin actually has responses of about 40% of patients who are FLT3 normal. But you can actually predict exactly which are those 40%. There are patients just like this. But you have to feed the midostaurin in and know that it inhibits all of these and all the downstream things that get inhibited when you give the midostaurin. And let's see, so it normalizes this, it normalizes this, and then it normalizes all these because it's normalizing the whole pathway here. And then it normalizes all these, and next thing you know, the patient has a response. But it's very hard to know this. I just want to reassure you, it works in real life. Very high positive and negative predictive value if you treat according to this report. And here's some combinations that the report gives you. And here's the one that I really want to share with you, because I was discussing with some friends, where would you learn more? Here, of course, resonancelehealth.org. This is from a neuroblastoma patient. This patient was referred for my attention after 3 relapses, and they sent this report, and they said, what do we do with this patient? And here's the top combination and standard of care treatments. No research drugs involved here. Look at this, the top three, sorafenib plus dactinomycin, trametinib plus dactinomycin, everolimus plus dactinomycin. Who here in this room has ever given dactinomycin to a neuroblastoma patient? Nobody, right? And I know dactinomycin is expensive in some countries, it goes on shortage in some countries, but what if we could add it to neuroblastoma therapy and actually cure more people without, doing double transplant and morbid surgery and radiation? Maybe dactinomycin could get us a little bit of the way there, or maybe some of these 3 targeted therapies that are available off the shelf. So these are also quite expensive and sometimes difficult. But I was just thinking, for this 3rd relapse patient, if I were her parents, I would have given her sorafenib plus dactinomycin, or whichever of these 3 that I could afford, plus dactinomycin, because why not give it a try based on the specific genome of this patient? And our time is up. So I want to finish with this final idea. Targeted therapies are less important than effective therapies. Effective therapies, this is St. Jude total 1 through 4, 5 through 9, 10, 11, 12, 13, 14, 15, and total 16 had an 88% event-free survival. What got better? What changed? The treatment. The treatment changed, so the prognosis changed. And the most important prognostic factor, you got it, it's the treatment. So what happened here? Oh, I also think it's fun. I love this slide here, so I hope you'll take it, because methotrexate and 6-MP were approved in the US in 1953. Remember, penicillin was like 1947. So this is like a few years after penicillin, we had the first effective agents. And I would never want anyone to say, oh, I use targeted therapy, I don't use mercaptopurine. I use targeted therapy, I don't use methotrexate. Well, these are great drugs. Even if they're 70 years old almost, they're still great. They work great. They save lives. So imatinib and dasatinib, perfect if you happen to be in this little red sliver, perfect. But asparaginase also is very important for Philadelphia chromosome-positive ALL. Hey, and not only that, the asparaginase treats every other group. So you don't even have to know what the mutation is to cure this patient with asparaginase therapy. And here's just some examples: more asparaginase, less, more asparaginase, less, more asparaginase, less. Adding more asparaginase to almost anything increases the event-free survival. Hey, surprise, prednisone, that classic from the 50s. Every single slice of the pie is sensitive to prednisone. So is it targeted? No, not at all. Or you could say it's targeted, but it hits every target. And that's the kind of targeted therapy I want, is something that'll help my leukemia no matter which mutation I have. So we don't need 20 different targeted therapies. Yes, we want imatinib and dasatinib, but we need asparaginase, prednisone, mercaptopurine. Surprise, every subgroup is targeted effectively by mercaptopurine. Very, very effectively. So effectively that if you skip more than 10%, you have a 4-fold risk of relapse. Well, 3.9-fold increased risk of relapse. So giving this mercaptopurine right is more important than dasatinib versus imatinib and many other questions. So I hope I have left you with the one central message, which is molecular biology is very important, but it's hard to figure out. And we're going to need technologies like CellWorks and similar things to make sense of patients who have multiple driver mutations. But targeted therapies do not replace other effective and non-targeted therapies. So I really thank you for inviting me. I can't wait to visit Pakistan in person for the first time one of these days when we're able to. And I would love to take any questions if we have time.
Thank you so much. That was, again, it was excellent and very encouraging for us in developing countries where we have limited access to molecular studies, and just knowing that we can use traditional agents and get excellent results if we do it right is very, very encouraging. We do have time for question and answers at the end, about 15 minutes. So we will move on to the next presentation and then do the question answers at the end. So I'd like to invite our next speaker, Dr. Mary Taj. She's, I think, very well known to everywhere here in Pakistan. She's a regular attendee of our symposium and PSPO meetings, and she is going to talk to us about transient abnormal myelopoiesis spectrum of clinical presentation. So Dr. Mary, if you can please share your screen and unmute your mic. Dr. Mary? Okay, I think we have her now. Okay.
Yeah. So can you see my, I need to share my screen, isn't it?
Yes, please. It's the green button at the bottom.
Just give me a second. Oh, I could hear you all very well, and now I can't. My screen.
We can hear you.
Yes. I just need to get to my talk. Can you see my screen now?
Yes, we can.
Okay,
Please
so
go
I
ahead.
can start. So thank you so much for inviting me. I love coming to Pakistan, and this year because of COVID, I can't. So this is the second best thing, and I'm very happy to join in today. So the topic you've given me is transient abnormal myelopoiesis, and this is a very rare condition, but it is important because from presentation in a pre-leukemic phase, up to 10 to 20% of patients can develop myeloid leukemia of Down syndrome. So this condition occurs in neonates with Down syndrome. It can present in a severe form where there is a 20% mortality at birth, and then some of these patients, 10 to 20% of them, can develop myeloid leukemia of Down syndrome. So in that sense, it is a very important condition that I'm happy to talk about. So the WHO definition for TAB, or this transient abnormal myelopoiesis, is increased peripheral blasts in neonates with Down syndrome. However, up to 98% of patients with Down syndrome can have megakaryocyte blasts. So it's not, it doesn't capture all these, it doesn't capture the patients who are at greatest risk of harm. So it turns out that this gene called GATA1, when it is mutated in neonates with Down syndrome or mosaic Down syndrome, when combined with an increased blast count or features suggestive of TAM in the clinical setting, is more likely to capture those patients who are at greatest risk of risk of harm. So this GATA1 with an increased percentage of blasts, and some people put this percentage as high as greater than 10%, is another definition of this condition. This condition has several names. Transient abnormal myelopoiesis is one. Transient myeloproliferative disorder was the old name, but transient leukemia is also gaining traction because it wants to focus on the fact that it is not quite such a benign condition, and at birth, they can, in the neonatal period, 20% of these patients can die. And it is very important to pick up those patients whose survival can be improved by giving chemotherapy at an early age. This condition is unique to Down syndrome or mosaic trisomy 21, the patients who can look phenotypically normal but have underlying a mixed population of trisomy 21 cells and normal cells. And this, in patients with this condition, you can see thrombocytopenia, polycythemia, and white cell abnormalities and megakaryoblast. Patients with Down syndrome, as you know, have an increased risk of leukemia, and the risk can be as high as 30 times the normal population. But this condition predisposes you to myeloid leukemia of Down syndrome, not acute lymphoblastic leukemia. So when we talk about TAM, we're talking about the risk of myeloid leukemia of Down syndrome. So this looks at the standardized incidence ratio. So these children with Down syndrome are very small in number, but they have a standardized incidence ratio of 153 of developing myeloid leukemia, which is very high. And this high risk is mainly in the 0 to 4 year age group. And then the older children get, older Down syndrome children also get it, but the ratio is, but the incidence is much less. Acute lymphoblastic leukemia, which we won't talk about, these children are also at a higher risk of getting that, but it's not quite as high as for myeloid leukemia. So in order to put this in clinical context, I am going to present a case study, a patient of ours that we traced from birth to the point where they developed myeloid leukemia and later on, because this particular patient was part of the Oxford Imperial Down syndrome cohort study and got regularly tested from birth on up till the time that this child developed myeloid leukemia. So this particular patient, diagnosed Down syndrome at birth, had neonatal jaundice that lasted up to 2 weeks and was diagnosed with TAM. The definition that this particular study used was presence of greater than 10% blasts in the first week of life and the GATA1 mutation. So this patient had close follow-up, recovered from TAM at 6 weeks of age, continued to have 3 monthly full blood count, peripheral smear, and GATA1 mutation monitoring. Patient lost GATA1 at the age of 1 year and 8 months, but a month later, the GATA1 reappeared. And this child then developed AML, GATA1 positive megakaryoblast leukemia at 1 year and 10 months of age. This patient was then treated on the Down syndrome AML protocol with a reduced amount of anthracyclines. The total anthracyclines were 240 milligrams per meter square. And now the child is off treatment and comes for late effects follow-up. Interestingly, all the patients with the GATA1 mutation at 6 months of age developed myeloid leukemia of Down syndrome in this particular study. So how can you pick up these patients who are most likely to develop myeloid leukemia at a later date? It turns out that blast cells cannot distinguish the patients who are going to develop myeloid leukemia, because 98% of Down syndrome children who with no features of TAM also have these giant megaplatelets and megakaryoblast. I seem to have lost my pointer. Oh, here it is. So with these big basophilic cytoplasm with blebs, megakaryocyte fragments, and circulating megakaryocytes, which are very similar to the picture we see in patients with TAM. The only thing is that the blast population is probably higher. The percentage of blasts is higher in patients with TAM, but they also have megakaryocyte fragments and circulating megakaryocytes. So when it comes to clinical presentation, the presentation in some patients with TAM can be very similar to neonatal leukemia, which is a very rare form of congenital leukemia, one seen in only 1 to 2% of patients. So these patients with TAM can have massive hepatosplenomegaly. They can have skin lesions that are papular or vesiculopustular kind of lesions, and can have uh, involvement of the liver, heart, and kidneys. Neonatal leukemia presents very similarly with these blueberry muffins, muffin-like skin lesions, which can be, which are usually blue, but can also be purple or brown. So I know neonatal leukemia is very rare, but in order to just differentiate the two, TAMS occurs in the context of Down syndrome or Down syndrome mosaic. Many patients can be asymptomatic, but others can have hepatosplenomegaly, skin lesions. In patients who have a very high white count, usually which can be greater than 100, you can have liver involvement with renal or cardiac failure, pleural effusions. On the peripheral blood, you see these megakaryoblists, which are large blasts with granular cytoplasm and bleb formation. Immunophenotyping shows stem cell markers, 34 and 117, myeloid markers, some platelet markers with CD56 and CD7, and these patients are by and large all GATA1 positive. Neonatal leukemia, which occurs in the first 4 weeks of life, forms very rare, less than 1% of childhood leukemia, also presents with hepatosplenomegaly, skin nodules called blueberry muffins, jaundice, ascites, pleural effusion, CNS disease. Patients with hyperleucosis, leukocytosis can have respiratory, cardiac, and renal failure. And when you look at their bone marrows, they can either have ALL, AML, or mixed phenotype acute leukemia. So let's see how we can dissect these further. Is there any way we can predict which patients are first to define TAM more TAM more completely, but then which of these are more at risk of developing myeloid leukemia? So as I mentioned, the Oxford Imperial Down syndrome cohort was a big study, a national study in the UK. And in their interim analysis in 2013, they had a total of 200 babies with Down syndrome, and they looked at GATA1 mutation and patients with greater than 10% blasts. With standard methodology, they were able to detect 8.5% of, by their definition, 8.5% of patients had TAM, and the rest, 91%, had no TAM. So then they looked at this population of TAM and to see how it could be distinguished from the rest of the patients, rest of the Down syndrome neonates without this condition. And it turns out that blast cells are seen in 98% of Down syndrome children with or without TAM, and the cells themselves cannot be distinguished from each other. What they did see was that non-Down syndrome children had up to about 2% blasts, Down syndrome maybe up to 10%, and then greater than 10%. When the blast count was greater than 10%, then there was more likelihood that these patients will be GATA1 positive and fit into this definition of TAM, but you can see that there is an overlap. So they looked at the children who could not be, the children with Down syndrome in whom GATA1 mutation could not be detected by conventional means, which is direct sequencing or HPLC, and did next generation sequencing on these patients. And they found that another 10% of patients with less than 10% blasts also had GATA1 GATA1 mutation. And they called this silent TAM because they had low blast percentage, and they clinically they did not have features of what a lot of people call transient leukemia. So they looked at the clinical features in patients with TAM and silent TAM, and tried to define if some clinical features were more specific for TAM or silent TAM. So in this bar graph, you can see that the black is Down syndrome with no TAM, purple is all GATA1 mutation patients, blue is silent TAM, and red is TAM. So jaundice, you can see that all four of them are there's not much difference in the percentage of patients who get jaundice. Hepatomegaly is more common in patients with TAM, but can also occur in patients with silent TAM or just Down syndrome patients in general. And splenomegaly, similarly, the percentages may be different, but is also seen in silent TAM and patients with Down syndrome patients with no TAM. Similarly, rash, more common in TAM, but can occur in other situations and well. And so the same with pericardial, pleural and pericardial effusion. So there are no clinical features that are specific for TAM. So in summary, no clinical features specific for TAM, although hepatosplenomegaly occurs in about 50% of cases. Greater than 98% of all Down syndrome neonates have circulating blasts. Most do not have GATA mutations, so the presence of blasts is not specific for TAM. Although most Down syndrome neonates with blasts greater than 10% in first week of life have GATA1 mutation, about 20% do not, even with next generation sequencing. So neither low platelets nor anemia identify neonates with TAM. However, a high white, if the white blood count is greater than 35, 45% of these babies had TAM. So what is the natural history of patients with TAM? This is again going back to the Oxford study. 130 neonates with Down syndrome had acquired GATA1 mutation at birth, and 4 of these patients died early. And the cause of death can be involvement of liver with fibrosis. It's not always the complications of TAM. And of these, 7 developed myeloid leukemia of Down syndrome. And of the ones with silent TAM, 1 developed myeloid leukemia of Down syndrome, whereas, so this gives a total of about 15% of patients went on to develop myeloid leukemia of Down syndrome. Interestingly, none of the patients who had no GATA1 mutations developed Down syndrome, and you can see this in the graph here, that no GATA1 mutations, nobody developed myeloid leukemia, and about 1% of silent TAM and 13% of patients with TAM went on to develop myeloid leukemia of Down syndrome. So progression following TAM, greater than 80% of patients with TAM undergo resolution of clinical and lab abnormalities within 3 months of age. Overall survival is approximately 80% with an event-free survival of 60%. The 20% mortality at birth, 10% is due to the complications of TAM, but half is due to hepatic failure secondary to fibrosis and blast infiltration. Even when the GATA1 gene disappears, it reappears when the patient develops myeloid leukemia of Down syndrome, and it has been studied and documented that this is the same clone that was present at birth. And 5 to 10% of patients with TAM, including silent TAM, actually it varies in different studies. So maybe 10 to 20% develop myeloid leukemia in Down syndrome. And all patients with myeloid leukemia with Down syndrome have the GATA1 mutation. So putting this into one big diagram showing the natural history and pathogenesis, patients with Down syndrome, trisomy 21, have perturbed hematopoiesis pre-birth, and it is seen that there is increased number of stem cells, megakaryocytes, and megakaryocyte erythroid precursors. And then 20 to 30% of these, due to the perturbed hematopoiesis, develop GATA1 mutation. And you see TAM, if the clone with GATA1 mutation is large, you get clinical TAM. And then patients who develop clonal expansion with development of other genes that can promote proliferation, they develop 10% develop myeloid leukemia of Down's syndrome. And a few patients with silent TAM also go into this pathway and develop myeloid leukemia. The patients who develop clonal extinction, some by 6 months of age, they don't go on to develop myeloid leukemia. And if there's no GATA1 mutation, there is no development of myeloid leukemia. It is to be remembered that GATA1 mutation itself can cause some thrombocytopenia, but it doesn't cause myeloid leukemia of Down syndrome. You need to have other mutations come into play, which then leads to the development of Down syndrome. So trisomy 21 itself causes a perturbation of the fetal level hematopoiesis, and then there is megakaryocytic lineage differentiation is also hampered. But combined with these GATA1 mutations that then develop, it's those patients that develop the blast percentage and clinical features that we call TAM. I'm just now going to go on to the management. So peripheral blasts disappear in uncomplicated transient leukemia or TAM within about 36 days. This was shown in a COG study. 20% of these clinical TAM cases develop myeloid leukemia. And then if you use more sensitive techniques, you can pick up silent transient leukemia, and the progression in these patients is 5 to 10%. So patients with Down syndrome who are monitored for other complications should also have a full blood count every 3 months for the first 2 years, and then every 6 months until 4 years of age. And after that, the risk of Down syndrome, of myeloid leukemia goes down, and you can just monitor them clinically. So the value of monitoring all cases with TAM or transient leukemia for the persistence of GATA1 mutation has not been demonstrated as yet. So this should not be routinely done, but if it's available, it can be a resource. So these patients can have multiple clones up to 6, and myeloid leukemia can occur from a minor clone sometimes. And in the Oxford Imperial study, all patients with persistent GATA1 at 6 months of age developed myeloid leukemia. If you are monitoring these patients with a blood film, patients who develop thrombocytopenia or features of MDAs could then have GATA1 mutation tested. So this is a flow diagram which tells you which patients of TAM should be treated. Every patient should have a full blood count. Every patient with Down syndrome should have a full blood count for estimation of peripheral blasts and percentage. If the blast count is high, you might want to test them for mosaic trisomy 21, and then do a full clinical examination looking at organomegaly, a small percentage, develop features of hydrops fetalis prior to birth, and then pleural and pericardial effusions and skin rashes. If the blasts are greater than 10%, then these patients are diagnosed as TAM or transient leukemia. Look for features of life-threatening symptoms like multi-organ failure, white count greater than 10%, bilirubin greater than 83, hepatosplenomegaly, and which can cause respiratory feeding complications, pleural pericardial effusion. So you do a complete assessment, and if these features are present, then the mortality can be high, and so these patients should be treated with low dose cytarabine. This is the BFM protocol. I think COG treated these patients with a higher dose of cytarabine, and their event-free survival was about 50%, whereas the BFM data showed about 70 to 80% survival for these patients who have life-threatening symptoms. So monitor until counts recover, monitor for developing liver involvement, because up to 10% of these children will die because of hepatic fibrosis despite treatment with cytarabine. And consider GATA1 mutation analysis if available. In patients who have less than 10% blasts, TAM or transient leukemia is unlikely, and GATA1 mutation is not routinely indicated. So TAM with life-threatening symptoms have a 20% mortality if left untreated. Exchange transfusion and leukapheresis may help in the acute setting. Liver disease may take a different course, and patients may die despite peripheral blast clearance. And there is no evidence to support that routine use of cytarabine in neonates can prevent the later development of myeloid leukemia. So it should only be used in those cases where there are life-threatening symptoms. So in summary, trisomy 21 causes perturbation of the fetal hematopoiesis. Some of these patients, up to 10%, develop GATA1 mutations. The ones with higher clone number, larger clones and blast greater than 10% develop TAM and its clinical features. Silent TAM is seen in another 10%. The mortality of TAM is about 20%, and 10% is because of hepatic fibrosis and failure. 10 to 20% run the risk of developing myeloid leukemia, and the ones with clinical symptoms and a higher percentage of blasts are more likely to develop myeloid leukemia. So TAM can have life-threatening symptoms, and those patients should be treated with cytarabine, but treatment of TAM does not prevent myeloid leukemia. So in the end, thank you very much for listening. I'm just sharing some of my COVID pictures, sunflower, and pictures from some walks. So thank you very much. I'm happy to take questions.
Okay. Thank you everyone for your participation. I would like to invite all the panelists to please unmute their mics and maybe turn on their videos, and we can address some of the questions that have been posted. And please, if anyone has any questions, go ahead and post them in the question answer box so we can get them to our panelists and speakers. We have one question from Dr. Komal Seher. She's one of the Pediatric Oncology Fellows at Shaukat Khanum Hospital, and she wants to ask Dr. Scott Howard. She's asking asking, do patients with the Philadelphia-like ALL respond to just escalation of therapy post-induction without addition of Dasatinib? As in developing countries like us, we may not be able to detect this class of mutations. So I'll appreciate if you can answer that for her.
Yes, they do. Great question. Remember, 82% event-free survival with MRD-based therapy, with no ruxolitinib, no dasatinib, just chemo. So, really good question.
Thank you. I think while we're waiting for other people to post questions, I had a question about the shortening of maintenance for boys, because that's something we still have not moved to in Pakistan. We're still doing the 3 years for boys. And it's an idea we've been playing with, at least at Shaukat Khanum, for a while, but we end up not going to it because we're following the UK ALL guidelines, which still gives 3 years for boys. So since Dr. Mary is also here from UK, I thought, if you can both share your thoughts about shortening maintenance for boys, because it's a huge burden for our patients that have to travel from very far to come for an extra year. So please share your thoughts on that.
We have to arm wrestle, Mary.
Oh, I mean, for us, I think in the next protocol, we are going to go on to 2 years, but there's going to be a much greater reliance on MRD testing for BCR-able like mutations, and trying to pick up the higher risk groups who are treated with much more intensive treatment early on. So with that, I think the lower risk group is going to get a much lesser treatment, but there is so much reliance on testing for cytogenetics and with MRD that we feel that it would be safe to reduce their treatments. But because these treatments are now much more intensive and as Scott said, there's much more reliance on picking up higher risk groups at an earlier age, 2 years of treatment will come into force. We're also going to be using high dose methotrexate in more of the intermediate and high risk groups. So it's very difficult to give blanket advice because, as Scott says, it all depends on the treatment and how intensive it is. We went to 3 years because our boys weren't doing well on our old protocol. And in fact, we followed the COG guidelines at that time and switched from 2 to 3 years. But then as the treatment has intensified and improved, we are going back to 2 years of treatment for boys in the next trial. But it's difficult to give blanket advice. It all depends on treatment. And
yeah, and it's interesting to compare this to Black versus white in the United States, because there were a series of studies where Black patients and Hispanic patients did worse than Caucasian patients. And so we never, though, modified therapy based on Hispanic or Black. So Hispanic sometimes modified, but only based on, their genomics. So they had a higher incidence of certain mutations, but the modification was based on the mutation, not being Hispanic. But what's interesting is in total 10, 11, and 12 protocols, the Black patients did about 10% worse. Total 13, 14, 15, 16, equal. And so again, it's just like what you said, Mary, the rest of the treatment changed. They're still Black, they're still white, they're still Hispanic, but everybody's rising up. But the Black patients rose up even faster than the white patients and caught up. And so the thought was, some people said, no, it's psychosocial problems, but at St. Jude, there's a guest house, there's social workers, there's free everything. So you can't have a psychosocial problem at St. Jude because it's definitively solved by the support that the patient gets. So then actually Dr. Pui published this to say Black and white equal if great treatment and great supportive care. And I thought this was a really good message. I think we're going to say the same for boys and girls. Is great treatment, great supportive care, they come out the same. The other thing I would love to know in Pakistan is what happens during that year, that final year of maintenance. Is there even one toxic death during that time? Because if you tell me there's 0 toxic death, 0 morbidity, just nuisance, then we can have the discussion. But if you tell me there's 2% toxic death, there's only a 2% difference in COG of thousands of patients, 85% versus 87%. So if you think you're going to gain that 2%, but you're going to lose even a handful of patients, for any reason, from neutropenia, from liver, from anything, then it's definitely, I would definitely go down to 2 years for everybody. Right now, today, if you have your own data. Or you could even say we're going to go down on patients who don't live in Lahore or don't live in Karachi. If you're out of town, you're getting 2 years period, because we know the back and forth is going to be too much. Something like
Right.
that.
Yeah, I mean, we don't actually have the data collected to answer that question, but it's rare to see toxic deaths during maintenance. I mean, they do happen, but it's rare. The issue sometimes is that they've gone so far away. Sometimes if they do get neutropenic, they can't make it to the hospital, and then that's an issue. And they may, complications may happen locally because they don't get appropriate management there. So yes, it is a huge problem socially and economically for people to travel back and forth. There's another question in the question answers for Dr. Mary. The question is, as we see that additional hits are needed after GATA1 for developing MLDS, then what is the clinical significance of monitoring GATA1 mutation in TAM recovered patients?
TAM recovered patients. So, I mean, there is no study that shows that monitoring for GATA1 mutation is cost effective and is likely to save lives. But if you were if you follow these patients with GATA1 mutation, a lot of patients lose their GATA1 mutation clone by 6 months of age, and these patients are less likely to develop myeloid leukemia of Down syndrome. If they continue to have GATA1 mutation beyond 6 months of age, like this patient that I presented had. She had GATA1 mutation up to the age of 1 year and 8 months. These patients are more likely to develop myeloid leukemia of Down syndrome. But if you were asking, is it necessary to be monitoring them with GATA mutation? It isn't. I mean, you could monitor them with just full blood count and differential. And if they're starting to develop thrombocytopenia and other symptom, features of MDS on peripheral film, you could keep a closer eye on them and maybe do a bone marrow at some point to see what was happening there. So I don't think there is data to show that GATA1 mutation. Is that the question? Is GATA1 mutation monitoring necessary?
I think that's what I understood as well.
Yes. I don't think it is, and I don't think it is standard of care, but just that different studies have monitored GATA1 in order to understand what TAM is and which of these patients are going to develop myeloid leukemia of Down syndrome.
Thank you so much for your excellent talks and for taking our questions. And I think there are more questions that are in the chat that we can maybe address in the chat, because we're running out of time here because the next session needs to start here. But again, it was really great. We learned a lot, and thank you everyone for your participation. And, I know there's time differences and you guys have to stay up to do these for us, and we really appreciate it. And we appreciate all that we have learned from you. Everyone, please do stay or come back in like 15 minutes for the next session. We have 2 excellent talks on Ewing sarcoma in the next session, and we will also be reviewing our COVID data for pediatric oncology patients in the next session. So please join us again in another 10 minutes. Everyone gets 10 minutes for coffee.
Good coffee.
Goodbye.
Guys. Good bug.